Hello there, I'm Dr Srishti, Banerjee, Masters of Physiotherapy in Neurology, working as an Assistant Professor for LG Institute of Physiotherapy. Our topic for today is neuromuscular coordination. Now, what do you understand by coordination? Coordination is a smooth, rhythmic, accurate, harmonial activity. Okay, it is smooth. There are no jerky movements, there are no breaks. It is a smooth activity which is rhythmic in nature, okay, accurate and harmonial. Harmonial means it activates a particular sequence of muscles for a particular activity, and the activity is produced in correct sequence of the muscle. For example, I have to touch my nose here with my finger. Okay, this is a smooth rhythmic activity. So there are a group of muscles starting from my elbow flexors, then my forearm muscles and the flexors of the finger. They work in one sequence to provide me with a smooth movement. Now, whenever there is an abnormality in this, that is known as incoordination or asynergia. It is totally opposite of that of the smooth movements become jerky. They are inaccurate in nature, non-purposeful and done by group of muscles. Sometimes the muscles which are not required also get into this activity. There are a variety of causes. Okay, so first is flaccidity. Flaccidity is reduction in the muscle tone. Muscle tone is the normal amount of resistance the muscle provides at rest. Flaccidity occurs whenever the muscle at the reduction there is a reduction in the muscle tone. This can be due to affection to the higher centers, like in stroke or in spinal cord level at spinal cord injury. These flaccid muscles are not able to perform a smooth rhythmic movement because of weakness, because of reduction in the muscle tone. Secondly, cerebellar ataxia. Cerebellar ataxia is specifically used in terms of ataxic gait. When there is a pathology in the cerebellum, this coordination between the movements is disturbed. This is categorized by dyssynergia. It is categorized by overshoot and undershoot. For example, I have to touch my nose with this finger. The nose is my target. So if I am a patient of cerebellar ataxia, my target is here, but I will go like this. So this is the overshoot reaction, or I will go like this. This is the undershoot reaction, which is typically seen in cerebellar ataxia. Then it is also categorized by a variety of forms, such as it has speech difficulties, it has difficulty in rapid alternating movements. So these are all symptoms which are seen in cerebellar ataxia. Then there is loss of kinesthetic sensation. Kinesthetic sensation is the movement sense, the how your joints move. You know that, for example, this is my wrist, this is bent. I know, even with my eyes closed, I'll be knowing that my wrist is bending. So this is kinesthetic sensation. Okay, this kinesthetic sensation is not a condition, it is a symptom which is seen in variety of conditions, like Tabes dorsalis. Tabes dorsalis is a posterior column disease. Okay, it is an infection after syphilis. It is a posterior column disease affecting the sensation. One of the sensation lost is this kinesthetic sensation. Again, in syringomyelia, what happens is there is a syrinx or a cavity formed in the spinal cord. When it is formed in the spinal cord, it is syringomyelia. When it moves up, involves your brainstem, it is known as syringobulbia. Okay, so loss of kinesthetic sensation is a feature of all these conditions. Then sensory ataxic gait. Sensory ataxic gait is typically characterized by a high steppage gait. The patient excessively flexes his hip and knee and stamps the foot on the ground because there is a loss of sensations. Okay, so the patient feels as if he is walking on a cotton wool. because the sensations at the dorsum of his foot are impaired. The difference between cerebellar ataxic gait and sensory ataxic gait: in cerebellar ataxic gait, the patient walks with a wide base of support with his pelvis moving from side to side, also known as drunkard's gait. But in sensory ataxic gait, the patient walks with a stamping pattern. Okay, diabetes mellitus and leprosy is again characterized by polyneuritis. Due to this condition, there is an inflammation of the nerve. Therefore, the diabetes mellitus again leads to a neuropathy. It leads to a neuropathy, lack of sensations, known as diabetic polyneuropathy, affecting the sensations of the dorsum of your foot. Now, there are various tests for assessment of this incoordinated movements. Okay, so first is finger to nose test. Simple. From the your finger has to be touched to your nose. The abnormalities is overshoot, undershoot, tremors while reaching it. Okay, heel to sheen test. For example, this is my sheen, this is the heel. The heel of the opposite leg is dragged on the sheen of my tibia. So this can be, see, I'm normal, so this movement occurs very normally. But in patients with cerebral ataxia, the movement can occur in breaks, or the movement is jerky. Okay, then finger to finger test. Okay, this is how the finger to finger test. Then this is the therapist finger, this is the patient's finger. This finger to finger test can, again, it is characterized by overshoot or undershoot reactions. Rapid alternating movement specifically of your forearm. Okay, supination, pronation are again rapid alternating movements. Tapping your hand, okay, tapping your feet are again rapid alternating movements. In patients with incoordination, this is lost, like the rhythm of the movement is lost. Then this way for upper limb. For lower limb, finger to toe test. That is, I as a therapist, I will point out my finger like this, and the patient has to touch his great toe to my finger in supine lying or in high sitting, or in long sitting position. Heel to sheen test, again Romberg's test is the patient is asked to stand with his eyes closed, and we look for the sway, postural sway. Now, this was all about the test. Now, the gold standard treatment for treating incoordination is Frankel's exercise. Remember, this is one component of the treatment. If the patient has spasticity, you need to treat spasticity. If the patient has biomechanical abnormalities, you have to treat. If the patient has strength issues, you need to go for strengthening. If the muscle tone is flaccid, you have to work on that. Along with that, we can add up Frankel's exercise. It was designed by Dr. H.S. Frankel. First, he firstly designed this for patients with Tabes dorsalis who reported sensory ataxia, but now we can use in any type of incoordination. So there are 6 principles. See what happens if the patient is having a loss in kinesthetic sensations. See, we cannot restore kinesthetic sensation, right? So what we will be doing, we will be using alternate methods or alternate sensory pathways, such as vision, such as hearing. Okay, so these are the alternate pathways which can be used to compensate for kinesthetic sensory loss. So concentration is the patient should know that what he is doing. So specifically, we make the patient in a long sitting position, and we make him watch his movement. We make him concentrate on what movement he is doing. So he is using his vision to compensate for the kinesthetic loss. Second is precision. No jerky movements, no mistakes are allowed during learning, because whenever we are teaching any new movement, there occurs a phenomena in your central nervous system which is known as neuroplasticity. Neuroplasticity is learning that movement. So if the patient is not precise in that movement, he will learn, his central nervous system will learn a wrong movement. That is why we concentrate on a precise, accurate movement. No mistakes are allowed. Then speed and range. Remember, quick movements are easy to control, slow movements are difficult to control. Large joints are easy to control, small joints are difficult to control. So begin with faster, larger joint movement, progress to slower, smaller joint movements. Okay. Command is again a type of auditory feedback to the patient, okay, that will help in developing new pathways. Repetition, repeating one movement for a number of times will only lead to learning. Like, it is not like that if the patient is repeating a movement for 5 to 7 times he'll be accurate in that. No, repetition is an important component for neuroplasticity. Complication, once the patient is done with one stage of the movement, for example, if we are making him do a movement in supine or long sitting with his more than half of the body supported, he is perfect with that, then change. Okay, progress him with a less supported surface or with a less supported environment. Include dual tasking. Okay, so these are the examples of movement. See, these are the types of Frankel's exercise. For lower limb, first we begin with side lying gravity eliminated position, easy for the patient. Side lying knee flexion extension, side lying hip flexion extension. Now the patient is in half lying position. We draw certain marks like this. What we ask the patient to do, hip abduction and adduction, we ask the patient to place his limb on these marks. Again, knee flexion extension, hip flexion extension, we ask the patient to flex his knee and, for example, place it on 2, place it on 3, place it on 4. Okay, so this is how it is done. For upper limb, shoulder flexion extension, elbow flexion extension. Firstly, elbow flexion supination, supination pronation, elbow extension, supination pronation, wrist flexion extension. See, this should be firstly done with the patient supported. Okay, his upper limb should be supported on a table with the shoulder in abduction. Then once the patient is good with this activities, progress. Ask for a voluntary halt. For example, you are asking the patient to flex his elbow, ask him to suddenly stop. Okay, this is a halt. It can be either voluntarily or on command. Start with supported, move to unsupported. Okay, unsupported initially without a halt, then initially with voluntary halt, then with halt on command. Okay, these are the things we need to incorporate in progression. For example, you are making the patient touch your finger till this, then move, improve the range. Okay, then as I said, moving from unsupported from supported to unsupported surfaces, from half lying, make the patient in sitting, for flexion extension, abduction adduction. Okay, now this is an interesting thing. Make the patient sit on a chair and we use something like this. Okay, this, as you can see, these are the chair legs, the patient is sitting here. We as a therapist will say the number. For example, I am saying number 9, so he will put his foot on number 9, then I'll say number 8, then I'll say number 4. So this is how, initially slow then fast. Then sitting with lifting objects. Okay, from the table we can make him do pegboard activities and toilet training is done. Then walking. See, before moving on to walking, first of all we make the patient stand in parallel bar. Okay, see his stance. Then we ask for weight shift from right to left. This is done before we move to walking. Okay, then there is a instrument which is known as Frankel's mat. You can see these are the footprints. We can ask the patient to walk. See, you can see here 3 footprints, right? Initially the patient can walk with a wide base of support, then he can walk with a narrow base of support. This is about forward walking. Even side walking can be practiced on this Frankel's mat. Then turning, you can see this is turning. right and left. You can see we can draw this on the floor. He has to put his right foot here and turn with the left. Then again right foot here, turn with the left. Once the patient is done, this is known as step turning because the patient is taking steps with one foot. Once this is done, we can move towards pivot turning. See, as you can see here, this is the heel of the right foot. Okay, he has to turn. Keeping the heel stable on this circle, he has to turn with placing his foot on this left marking. So this is the heel, then it turns like this, like this, like this. With this is the left foot. For example, these are my 2 feet. Okay, this is the heel I'll place. I'll place the heel that will turn like this with my left foot moving. Okay, so this is about all about Frankel's exercises. Again, your hand movements can be trained. You can make the patient hold 2 dowels and you can stand in the front with your arm movements. The patient's limb movements are assisted. So this was all about Frankel's exercises for treating incoordination. Thank you.